going to talk about a topic which is rare in pediatric practice, but one which can have significant consequences overall. That is about thyrotoxicosis. So how common do you think, Dr. Vibha, is thyrotoxicosis in pediatric practice?
So thyrotoxicosis is basically very common in pediatric and it's not common in adults.
Yes. So roughly it's like 1 in 100,000. That is the sort of a figure. When we say thyrotoxicosis, we used to earlier use the term hyperthyroidism. So why don't we use the term anymore, Naveen?
Sir, basically thyrotoxicosis is elevated levels of thyroid hormones. This could be basically because of the increased production or because of the increased release. Hyperthyroidism basically increased production of the thyroid hormone.
So when people used to say hyperthyroidism, it would basically mean that it is increased production. But we will discuss that many causes because of destruction of thyroid also, which is there. So what we'll do today is that we will use different case scenarios to highlight about the complexities in terms of etiology, evaluation, and management of thyrotoxicosis. The key question is it thyrotoxicosis? What is the TSH status? What is the cause? We'll go step by step from there. So to identify thyrotoxicosis, you should be aware that when should you consider. So most of us know that if there is weight loss, if there is hyperdefecation, if there is tachycardia, tremor, sympathetic activity, we start thinking of thyrotoxicosis. But you should also be aware that if you have periodic paralysis, you should always think of thyrotoxicosis. And we'll discuss about one of those cases which may happen in that regards. Polyuria is also a manifestation of thyrotoxicosis, easy fatigability, worsening of overall school performance, myasthenia. These are all other indications where thyrotoxicosis should be considered. If you have sudden rise in thyroid hormone, you will have a lot of problems which is known as thyroid storm. So in this scenario, if your thyroid was uncontrolled and you do a surgery or you do a radioactive iodine, suddenly a lot of thyroid, which is already there in the thyroid, will come into the body. And that is going to cause the thyroid storm. It can also happen in infection settings. Your levels of thyroid will go hugely high, up to 100, 200, 3, 4, 5 times, 10 times the normal. And that will basically cause a significant problem in the form of cardiac failure, hyperthermia, tachycardia, palpitations, atrial fibrillation. So all those complications will be there. There could be encephalopathy, arrhythmias, and you will have hyperthermia in that regards. Now, which test shall we do to screen for thyrotoxicosis, Dr. Vibha?
TSH, T3 and T4.
Yes. So very importantly, as discussed, in cases of thyrotoxicosis, the TSH will be the first to go down. T4 will rise, but the rise of T3 will be much more. So if you just do FT4 TSH, you may still be confused. So in this scenario, you should do T3, FT4 and TSH. Why T3 and not FT3, Dr. Nani?
FT3 is not really.
So most assays of FT3 actually use a surrogate marker using T4. So they are not very good. So T3 total is what is recommended. Now the next status is it because of relief or production? So we need to know where the signal is coming. Is it TSH dependent or independent? Anybody whose FT4 is high, TSH should be 0, less than 0.1. So if it's undetectable, this is thyrotoxicosis. If it is on the higher side, any detectable, it is a TSH adenoma or resistance. This is what we've discussed. These are less than 0.01% of cases, so we won't be bothered about that. So most you will come there high FT4, low TSH. This is the typical picture you will see. Now, from there, the biggest question that you have to answer is it Graves' disease or it is thyroiditis? That is the big differential to look at. So in thyroiditis, because of antibody, viral infection or bacterial infection, there is a damage. There will be no eye signs and goiter. It will be a milder disease, which is self-limiting. There will be no radionuclide uptake in that scenario. While if you have Graves' disease because of a stimulating antibody, you will have eye signs and goiter. It will be a severe disease. There will be increased uptake and you would require anti-thyroid drugs to treat. So just to distinguish if it's a rapid course, if you have eye signs, if you have goiter, you have got very high levels of FT4, you have got bruit, which is a marker of vascularity of the thyroid gland, you are mostly dealing with Graves' disease. If there is a milder symptoms, absent eye signs, absent goiter, no bruit, marginally elevated FT4, it is most likely thyroiditis. Dr. Ruchira, what is the most common cause of thyrotoxicosis with eye signs? You've got eye signs and thyrotoxicosis. Most common cause? Graves, we've discussed that. Na? Vibha, what is the most common cause of thyrotoxicosis without eye signs? Yes, so you need to remember that even if the eye sign is not there, it can still be Graves' disease. So you cannot just say no eye sign does not mean that this is a thyroiditis rather than a thyrotoxicosis. So radionuclide scan will tell you the picture in that regards. So pointers against Graves are no goiter, age less than 1 year. So less than 1 year, like in diabetes, we say if the age is less than 1 year, think twice before you say it is type 1. It may be a maternal passage of thyroid or a TSH receptor activating mutation which can cause that. And that will give you a picture. Now, what about TRAB antibodies? There are two types of antibodies which are measured. One is a TSH receptor antibody. The other is the TSH stimulating immunoglobulin. TRAB versus TSI. Some people say TSH binding inhibitory immunoglobulin, TBII. What is the difference between TBII and TSI?
Basically, one is basically bio and the
yes. So when you say it is binding the TSH receptor, it can both activate or inactivate. But to prove that it is activating, you need a bioassay. So basically, immunoassay, you just see whether it will inhibit the TSH binding or not, which is the assay which is there. And you will study that. This is a low cost now available in most platforms. You can do this antibody. It will not tell you whether it is increased production or not, because it can be both blocking and stimulating. But suppose you have somebody with Graves' disease and these antibodies are positive. It can't be blocking antibody. It has to be stimulatory. So if you use clinical sense, you can use this also and get a good idea based upon that. Bioassays are actually, you will use specific cell membranes which are going to produce cyclic AMP. So it's going to be very, very complicated. Your trap will go there, it will start acting and then levels will go up. This is definitely gives you a functional status and it is very, very expensive. So the sensitivity, which one will be more sensitive? Trap or the functional ones? Immunoassay will be more sensitive. Specific would be the bioassay because it will only be positive in Graves. It won't be positive in thyroiditis. So if you have classical picture of Graves and somebody says, okay, stimulatory antibody is negative, you can then do a TRAB and you will know that this is positive because it's more sensitive. But I would say there is very limited role in routine clinical practice to measure antibodies, which condition it is very important. So in the pregnancy, so during pregnancy monitoring of mother, this will tell you how much likely is the baby to develop those complications from that regard. So Graves versus thyroiditis, limited role, more in terms of pregnancy. And earlier people used to say, okay, now the antibodies are negative, we can stop treatment in that regards. So thyroid scan is very important. We can use both iodine and technetium. It should be done if you have no eye signs and no goiter. And if you have a specific nodule, if there is no uptake, this is thyroiditis. If you have increased uptake, it is Graves' disease. You may have a toxic nodule or you may have a toxic MNG, which will give you the diagnosis in that regards. What about ultrasound? Limited role of ultrasound, largely if somebody doesn't want to go for a thyroid scan, which can be one condition in which a female will not like to go for a thyroid scan, or you would not recommend them to go for thyroid scan. So if you have a pregnant woman with thyrotoxicosis, if you have a doubt, then you can look for the blood flow vascularity. The other role where it is very effective is amiodarone-induced thyroiditis. There are two types of amiodarone-induced thyroiditis. One is thyroiditis, second is increased production. So their blood flow causes gives you a good information. So nodule and goiter can also be characterized in that setting. So before we start with cases, the approach, first thing is to look at nuclear scan. If somebody has got a big goiter, eye sign, very high FT4, you may say, okay, I don't have a facility easily available. I don't need to do it. Otherwise, scan should be done. Increase uptake with a solitary nodule is a toxic nodule, multiple areas toxic MNG, and if it is diffuse uptake, it's Graves. If it's decreased uptake, look for tenderness. No tenderness, chronic. Yes, subacute, very, very tender, very severe. That's a rare scenario of acute thyroiditis.
A 15-year-old female, and she presented with history of neck swelling. Now, this neck swelling was associated with features of thyrotoxicosis such as palpitations, excessive sweating, and weight loss. Now, on examination, her vitals were stable. There was tachycardia. BP was normal. Anthropometry was normal. On general physical examination, tremors were seen, but no eye signs were there. And she was menarche. So local examination, more importantly, a swelling was present. It was present on the right side, which was 4 by 3 centimeters. It was firm. The surface was smooth. The borders were well defined. It was mobile and not attached to the lower surface. The skin over the swelling was normal. It moved with deglutition, and there were no palpable lymph nodes in the neighboring areas. So initial impression just on examination was a toxic thyroid nodule. Of course, we didn't do the investigation still now, but there was a single nodule with features of hyperthyroidism and thyrotoxicosis. So initial investigation showed that the TSH was suppressed, T3 was high, and T4 both were high.
So if you compare these results with the previous report which Dr. Vibha was showing, do you think there's a difference?
These are these are not so high. I mean, they're not so high. Graves will have more than 2 or 3 times upper lung.
Here it was like above the limit. Now here it is marginally.
Marginally.
So this is again suggests that this is only the small area
nodule
of thyroid which is producing, not the entire
gland. Following that, an ultrasound was done, which showed a thyroid nodule 3.6 into 4 centimeters with multiple cystic areas. Now, FNAC was also done, which showed thyroid colloid nodule with hemorrhage. And finally, the technician maintenance scan showed an autonomous functional thyroid nodule.
So would you think that FNAC was essential in this?
So it was not essential. Any hyperfunctioning nodule does not require. So probably, sir, then ultrasound was done and they took time to get a scan supremate. That was.
Carry on.
Okay. Now, with this initial investigations, this is the clinical course. The diagnosis was made in December 2018, and the child underwent radioactive iodine therapy the next month. Now, following the radioactive therapy, there was persistence of at least symptoms that somewhat come down, but the TFT suggested thyrotoxicosis with the suppressed TSH and T4 still in the higher range. So again, in May, that is around 5 months following the initial radioactive iodine therapy, she underwent repeat radioactive iodine therapy. Following this, the child was started on thyroxine supplementation. There was good compliance with normal TFTs. On and off, there were some reports of elevated TSH, but T4 was normal all the time. In November 2020, there was a recurrence of thyroid swelling, which was on the right side. Ultrasound showed that a hyperechoic nodule, an 11 into 6, that is 1.1 into 0.6 centimeters in the superior pole. Now, here again, FNAC was repeated to see whether what is happening here, and FNAC showed a colloid nodule, benign category. TFT done was normal. So in this case also, nothing extra was done. No further management was done because TFTs were normal and it showed benign category. So from November 2020 to March 2022, thyroxine was continued and TFTs were normal. But now what has happened in March 2022 is again, there is increase in the size on physical examination. These are not associated with features of hypo or hyperthyroidism, but ultrasound shows increase in the size to up to 5 centimeters. Now the conundrum comes whether to go for a surgery following this, what to do. So going by the data, what was given at least in the ATA guidelines in 2016, if you look at the post-RAI, and if you look at the toxic solitary nodule, there is a 6 to 18% chance of treatment failure after every RAI of persistent hypothyroidism, and 3.5 to 5% risk of recurrent hypothyroidism following RAI. And in RAI, you can have euthyroidism, but there is a risk of hypothyroidism. Usually, if you give RAI, the risk of hypothyroidism is low, but it progresses if there is TRAP positive and a non-suppressed TSH after giving RAI. But none of these were in this patient. So again, the reason for recurrence is still a
So
dilemma.
what do you think is the underlying problem? Why does she have a nodule?
Is this basically recurrence? There's only the nodule is being developed, but there's no thyroid.
So there are two aspects. Why is the solitary nodule formed?
Initially, it was formed due to a hyperfunctioning nodule because of focus was there.
Why some cells start becoming hyperfunctioning? In most cases, if you do genetic study, you will find that there is a somatic mutation of the TSH receptor. So that happens in all cancer. There is some somatic mutation which is there. So only those cells are hyperactive. Now, what Naveen is saying is that nodule has increased in size, but it is not thyrotoxic. So it may be something else. Because if it was TSH receptor mutation, it would cause a problem. The main concern that we have is that in this case, radioactive iodine treatment was given before all those guidelines had come.
Yes,
so now, as we were discussing, is that if you have low dose radiation in a pediatric thyroid, there is a risk of malignancy subsequently, for which we are very, very careful in that regards. Because if you have a Graves, the entire thyroid is ablated, while in toxic nodule, you can't ablate the thyroid. That is the problem. So I think in this scenario, where you have multiple nodules which are appearing time and again, best would be to take a removal in that regard, so that there is no confusion subsequently. Although clinically they are benign, radiologically they are benign, definitely is benign. So for this 5 centimeter lesion, we have recommended surgery removal in that regard, which is interesting. So the biggest message of your case is?
There can be recurrence post RAI, and of course, children in pediatric age group should consider surgery more than RA in case of toxic nodules.
So toxic nodule surgery is the modality of choice. This recommendation is now very clear from ATA. The time we had done all that, it was not very, very clear. So this is again an important message to remember. That if you have a toxic nodule in children, go ahead for surgery. Candy is asking the use of carbimazole instead of methimazole. So carbimazole is a prodrug. It has got similar efficacy. The dose requirement may be a bit higher with carbimazole, but otherwise it is the same drug, so it doesn't make a big difference. Dr. Adelaide is saying, can we have Graves' disease without eye sign at the beginning of the disease? Yes. So this is an important point to remember. The most common cause of thyrotoxicosis with eye signs is Graves. Thyrotoxicosis without eye signs is Graves. So it can happen. Can you come back with definition of thyrotoxicosis and hyperthyroidism? So hyperthyroidism implies that you have got increased production of thyroid. While thyrotoxicosis can also be because of release of thyroid hormone. 14-year-old girl with thyroid swelling, nodules on ultrasound and negative antibodies. We don't do the uptake here. High T4 and low TSH, she's on neomarcazole for now. What can I do in this case? This looks like Graves' disease. So I think here what we need to do is that we should continue treatment and maybe try to see taper after around 18 months to 2 years, then we can go from there. Dr. Elizabeth is asking the prognostic factor, which did you say if not remission in 2 years, you should consider definitive treatment? Yes, this is important. So at the beginning, if you have a very young child, less than 10 years, prepubertal, male child, large goiter, FT4 is very high, and you have got a high level of TSH antibodies, if after 2 years you haven't achieved remission, go for a definitive therapy in that regards. Dr. Rajib is asking, is neonatal thyrotoxicosis, which is the drug of choice now? Again, it is methimazole along with beta blockers. That will be the main drug. You can use iodinated contrast, which can also be used in that scenario. Dr. Elizabeth is asking, how can you rule out pyriform sinus? Barium swallow. So barium swallow is considered to be the best test. So you look at, there is a connection between the thyroglossal area and the connection with the food area, and that's how you can get it from that regards. Treatment for T3 toxicosis, Dr. Rajib, again, the same treatment for any other condition, use antithyroid drugs and beta blockers. Why do we have bruin Graves? Because of increased vascularity, which is going to cause that. Dr. Namir is asking role of T3-T4 ratio in differentiating Graves from Hashi toxicosis. A lot of people talk about this because of the MDI activity, but this is not very important. I would say most important is eye signs, goiter, very high level of FT4, and if you have access to scan, that is the best test. That will tell you whether it is a thyrotoxicosis because of Graves or thyroiditis. In the first case presentation, why don't you try the block and replace treatment? We haven't focused much on management here, but block replacement management, which basically means you block and then you give thyroxine, is no longer recommended. Two reasons. One is that you are giving too much dose of antithyroid drugs, and all the side effects, the hepatic, the hematological, the vasculitis, they are dose dependent. So if you give too much dose, you will cause more adverse effects in that scenario. And second, it doesn't improve your remission rate. So we don't use block replacement in that scenario. Dr. Kamlesh is asking why periodic paralysis was improved after IV fluid administration. So periodic paralysis basically is anyway a temporary phenomena. It will improve after some time. It usually is precipitated by a very high level of intake of glucose in this case. So if you give some potassium, they will improve. Otherwise also they will improve after some time. Now, Dr. Kamlesh is asking how long Allegro antiallergic medication required. So this is an important issue. If it's a mild infection, like in mild urticaria, it improves after 2 to 4 weeks. But in severe cases, you may require for a long time. Months also may be required. What are the arguments to stop the antithyroid drug? So if you are on a very low dose, maybe around 2.5 to 5 milligrams of methimazole and thyroid function is normal, around 1.5 to 2 years of treatment, that is when you can give a trial. You have to monitor the child lifelong because all of these disorders can come back again. You have to be cautious about it. Dr. Elizabeth is talking about specific definition for being in remission. Yes, Dr. Elizabeth, the definition is that of antithyroid drug, for 1 year, you are either hypo or euthyroid. So you are not hyperthyroid 1 year after stopping treatment. That is how you define the remission in that scenario. So I think this was a very, very great discussion. What are the cause of polyuria in thyrotoxicosis? It is a form of NDI. So hypercalcemia, hypokalemia, and hyperthyroidism, they are all associated with impaired concentration of urine. So that causes a polyuria which happens in that scenario. So I think there were a lot of questions. We'll just have one slide on overview of management and then we will close. We'll have another session of management subsequently. So the initial treatment basically is beta blockers along with methimazole. Now, which beta blocker to choose? If you have a patient who has got history of asthma, then you should not use propranolol. You should use metoprolol, which is slightly better. Atenolol is also some people use. It is more selective. It doesn't cause CNS symptoms. Otherwise, we use beta blocker is propranolol. And we use long-acting beta blockers because the metabolism is hyperactive. Even long-acting becomes short-acting. So you may have to give up to 8 hourly. So 2 milligram per kg up to 8 hourly is there. If there is a reactive disease, you start on metoprolol. If you have some lethargy, weakness, atenolol is also good enough. You start methimazole. So there is no confusion. I would say the first treatment is methimazole. Start around 0.5 to 0.6 milligram per kg with beta blockers. Now, if you have a small thyroid, female gender, pubertal, low TRAb levels, and FT4 is below 50, more chance of remission. Opposite, less chance of remission. Now, after that, you see, yes, the patient is fine. So around 24 months, you may consider tapering and stopping the treatment at that point of time. As soon as your FT4 becomes normal, half the dose. Otherwise, you will develop severe hypothyroidism. If there is no response or there are adverse effects like hepatotoxicity, low neutrophil counts, then you have to think of alternative treatment in that regards. Now, one word about agranulocytosis, it usually happens in the first 100 days of treatment, and it is usually associated with the ANC absolute neutrophil count less than 500. So if your neutrophils are above 1500, nothing to worry. If it's 500 to 1500, in that case, you stop temporarily, start after 2 weeks. Less than 500, contraindication. Don't start ever, think of alternate treatment. Now, then if your age is less than 5 years, as was there in the case that you had presented, you will only treatment which can be given is surgical management. No other option. You can't give radioactive iodine. 5 to 10 years, you can give radioactive iodine. More than 10, definitely you can give radioactive iodine. Then if your size of goiter is huge, which is more than 80 grams, you should do surgery is the only option. While if it's smaller, you can go for radioactive iodine. Now, there is one group of people who would say if you have somebody who is beyond 10 years of age, who has got a reasonably big goiter, very high thyroid, very high antibody levels, you can also offer direct radioactive iodine therapy as a primary care. But there also you will have to give methimazole to control before you go for radioactive iodine. So I think the simplest approach is start methimazole irrespective of all these risk factors. If these risk factors are absent, 2 years, stop treatment and see what happens. If despite 2 years no remission is happening, go ahead with definitive therapy. The options are either iodine therapy, which you can think of, which is best because it doesn't require surgical intervention beyond 5 years and no ophthalmopathy, no eye signs, and a size less than 80 grams. Think of iodine. If there are eye signs or if the size is very much, go for surgery. Iodine therapy can worsen eye signs. This is something you need to be aware of. So what we've done today, we've gone through the overall aspects of evaluation and management of thyrotoxicosis using 4 cases. One with unusual presentation who required radioactive iodine therapy. The second who developed adverse reactions in which we were able to manage with antihistaminics. Third with a toxic nodule for which radioactive iodine was given. But now because of large nodule, we might go for surgery. And finally, thyroiditis, where scan clearly made the diagnosis. And the big message there was that you may have some thyroid enlargement which is there, but it is not like Graves. It is more like thyroid. It was more like a Hashimoto-like picture in that scenario.